Yeah, hello everybody. I'm Emmanuel. I'm glad to be back here. I'm also glad I'm not a social media guy, so otherwise I would have found out quite a long time ago that I'm that I'm a number 4, so running into problems. Sometimes it's better to not know. Okay. Yeah, we'll discuss that. I'm presenting the team here. The names, I'm not going to go through all the names here, of the team that we do remote monitoring of neurodegeneration through speech. Let me quickly give you an overview of what I'm going to talk about. I will talk a little bit about the motivation. Why is this an important question? I will say a little bit of how is the degree of the most prevalent neurodegenerative disorders, that is Alzheimer's and Parkinson, normally done. We'll talk a little bit about what is the state of the art, how is typically the data collected and analyzed, say a little bit about our vision that we have, how to improve that, and that is just the speech-based monitoring. Then say a little bit about additional data for the workshop that we collected in the time in the last half year, and then expand a little bit on the planned research questions and end up with a summary. So the two most prevalent neurodegenerative disorders are Alzheimer's disease, with roughly 50 million people affected worldwide, and Parkinson with about 6 million. And I think this shows here we're about here, and this shows that this is an increasing problem just because the aging population in Europe and in the United States and Japan and other countries, where because people are getting older, the number of affected people is really on the rise. So Alzheimer's disease is a progressive neurodegenerative dementia characterized by decline in cognitive abilities, that is, you lose memory, reasoning, social abilities, linguistic abilities, and functional capacities like, making decisions. It affects older adults, and 1 in 9 adults over 65 and 1 in 3 over 85 is affected. It has a progressive loss of memory and brain function, behavior and personality. There is basically no cure and very limited treatment options, but still that means that it's worth it. I'll show in a second. The caregivers have to provide an increasing amount of assistance from light to complete care. And it's a very huge impact on the individuals, the affected individuals, but also on their families and caregivers. And it is a very big cost factor. You might ask, well, why is it worth... Oops, sorry. Yeah. Oh, sorry. Parkinson disease, the other one, the other disorder I'm going to talk about is also a degenerative disorder of the central nervous system. It has motor and non-motor deficits. Motor symptoms are shaking, rigidity, problems with movement and speech is one of the early indicators. It has non-motor symptoms concerning sleep and emotion, and articulation and phonation is affected in about 70 to 90% of the speakers with PD. And it's a very early indicator, so it's really worth looking into speech. You might ask if there is no cure, why deal with it? What I tried to show here on the slide is that you have this decreasing competence in, you have certain, for instance, with Alzheimer's, certain restriction of memory and thinking. But then you have functional restrictions, like you cannot travel alone anymore, you can't get dressed anymore, choice of clothes, beginning loss of speech and writing, behavioral problems, and complete outside care. And what we would like to do is just try to prolong this period where people can still live a life in dignity. That is, if we can have some treatment, then we can lower over time. We can prolong the time when people where people have a less severe stage and can live self-independent. So, how is the degree assessed once you're diagnosed? For Alzheimer, we have the mini-mental state exam, which is a number between 0 and 30. And so, for instance, if the people are questions like, what is the year, what is the season, or I would like you to count backward from 100 by sevens, or spell the word world backwards, and so on. And these questions, you get a certain point, and you know, the lower number of points you get, the higher the degree of Alzheimer's. Parkinson is normally assessed with the Movement Disorder Society Unified Parkinson Disease Grading Scale, so the UPDRS. There's different aspects of the UPDRS. The one that concerns motor activities is the UPDRS Part 3. It ranges from 0 to 132, concerning 33 questions. Now, only one of those concerns speech, though. So the evaluation of that question is, you know, normal means no speech problem, loss of modulation, diction or volume, but still all words easy to understand is 1, and it goes all the way to severe. Most speech is difficult to understand and unintelligible. Other questions concern things like facial expression. So observe the patient sitting at the rest for 10 seconds without talking and also while talking. Observe eye blink frequency, masked faces, and loss of facial expression. And then you also have normal facial expression, minimal masked faces manifested only by decreased frequency of blinking, severe masked faces with lips parted most of the time when the mouth is at rest. And other things like you look at the left and the right hand and do finger tapping, and you say no problem, all the way up to cannot or can only barely perform the task because of slowing, interruptions, or decrements. So, as you see, this assessment concerns the motor activities, other like the social abilities and so on, but it's only slightly related to speech. Now, this is the assessment you typically have for people. Now let's look at, and I'm not saying this is bad. I mean, we're doing the same. We started doing the same things, but typically, how do people then look at research at what is the influence? How can you measure something? Very typically, what we do is we keep as many influencing factors constant as possible. What does that mean? Well, for instance, one of the things when you collect a group of people affected by pathology, you exclude non-natives because you're looking at speech and you want to cut that out, so a non-native is not included into the affected people. Or you exclude people with other known neurological diseases because you say, I'm looking at Alzheimer's, so I'm not looking at this and that. Then you give them the identical task. You sit them in a clinical surrounding. You say, okay, perform this and this and that. Finger tapping, what I just said. Identical recording conditions. You want to have as good a speech signal as possible, so you exclude certain things. You don't let them perform things during the day, but you sit there. Some of our data, for instance, were even collected in a soundproof booth. You always have an accompanying expert sitting there. So it could be a medical student, it could be a neurologist. He sits there and says, why don't you do this task? If he's doing it wrong, he said, well, okay, no problem, let's start over. So it's defined, and the guy makes sure that everything is done the way you want it. And then you get the affected group and an age and sex matched control group. And then basically what you do is you look for significant differences in these two corpora. And very typical, of course, if it has to do with the acoustics, you like to do a task where you know what the person is supposed to do. So you have things like isolated vowels, you have read sentences, you have read stories, so things where you know what the person is going to say. And also you might have dedicated vocabulary. For instance, with Parkinson, you have words like pataka, where you change the place of articulation for the plosive from bilabial to alveolar to velar. And you do that very often, and you see how fast can he change his place of articulation. So the good thing is, for an automatic analysis, if we have that, we know what the person will say, and then we turn the speech recognition around. Because we say, okay, let me not look at what he said, but because I know that's what he said, let me try to see, can I really recognize that? And then from comparing from the targeted sequence of words or of the sentence to how much did I recognize automatically, I have already an intelligibility measure. And it's been shown in many different applications that a speech recognition system is actually a pretty good simulation of human intelligibility measurements if you have a naive listener. But of course that doesn't give you any hint on the linguistic competences, which is especially important for Alzheimer. Okay, but again, you want to keep it as a little bit, you want to know when you analyze, okay, now he's talking about a certain subject. And so typically things in Alzheimer and dementia tests are things like name all animals that you can think of. Okay? Or describe the following image. And this is an image, I'll come back to that later. It's a famous image that's done a lot in the analysis of dementia, the so-called cookie theft. Or what did you do yesterday? What did you do yesterday is a little bit less predictive. I mean, if you have an image, you already zoom into a certain subject. And with things like name all animals or describe an image, it's also important, for instance, describe the animals. Not only how many animals did the person describe, but also what was the sequence. Is there a certain order of these words? Okay. So, if the linguistic language level is affected, we use this kind of tests where we don't exactly know, but we try to still circle it down to a small amount by giving it a specific task. Otherwise, for the acoustics, we can ask them to read sentences. This is not communication, but it's as close to communication as possible. Now, what we would like to do is to, as I said, prolong the period of people living independently. And typically you have a situation where their state is changing slowly. And typically you have a situation where they go for a regular checkup over a longer period of time. I mean, the time between two checkups is a longer period. It could be 3 months, it could be 6 months, it could be a year. And what if you want this independent living, you kind of have to monitor people in between. So our vision is an unobtrusive screening of people with speech-related disorders, going beyond dementia and Parkinson, depression. There's other things like stuttering. If you come from a therapy of stuttering, and you would like to monitor, does the stuttering event, do they change over time? Is it at a point where I say, hey, listen, you're losing it. Why don't you come back and think about, what did you learn in therapy? So it goes beyond, but still we want to look at it with the dementia and the Parkinson. So as I said, we have a long interval between dedicated medical exams, somewhere between 3 months and 12 months. And often patients don't go. If everything is fine, I'm not going to even go, because it's bothering to go. I have to take a day off. I have to go to clinic. I might have to travel far. So sometimes people don't go. Also, early detection is currently difficult because people only go to certain screenings or diagnostics if it's kind of, if the signs are so inevitable. So this unobtrusive screening might be also a good thing to detect. As I said, the state could slowly decline, requiring adjustment during that interval. So the system must be able to provide some information to some server. Okay, I did find a certain change. Is it the change big enough to intervene, to call the person, and to actively contact them? The other thing is, which is important, when you go after 6 months, the examiner would like to have like an executive summary. He would like to know what happened during the last 6 months. And typically, you ask then the person, how has it been in the last 6 months? And of course, you have this, you see the guy with the white coat, and then all these self-reports are not usually as good as possible and as true. It's this examining situation, and Christy is just nodding because that's exact same situation there. And you might not remember the guy because the last time he was there, the lady is now who examined the patient is now on a maternal leave or so, or on vacation, and now you see the guy for the first time, and the only thing you have is a 2-page history or so. And so this executive summary of what happened during the last 6 months might be a very, very helpful thing. People, when you talk to neurologists, they say, oh, that would be great to have. And of course, there's the other thing. That's privacy. People have a right to have privacy even though they're monitored. So basically what we want is a smartphone that what we envision as a health buddy. And I demonstrated that on Friday. I called Hinek and said, hi, I'm giving a talk, and then I showed that, it only records my language, only records my side of the conversation, and it started doing an analysis as soon as I hung up. Okay, so basically what can we do is we can, after the system after I finish my phone call, I can do certain statistics about my communication behavior. And I increment my statistic. Every time I do a phone call, I have certain features that I have, and I can use them to increment my descriptive statistics of the communication behavior. What kind of things would that be? How often does the person use the phone? So if I have a 1 week, a 1 month period, I can say, how often has the person used the phone? And I can compare over the month before, and then if I go to my regular checkup, I have this executive summary that says thing. Or how often does the person call somebody from the phone book? That's an important information. My smartphone has so much information about me. If I call and the number is a number from the phone book, that means I'm calling a friend. If I call somebody else, then that call, I want to reserve a hotel or something like that, that's probably not in the phone book, or then that call has a certain different characteristic. How often does the person initiate a call? How often is he called? Very different. And at what time of the day does the person communicate? And we just heard in the last talk that that's also a very important thing. If somebody has sleep disorders as a side effect of the disorder, then they might communicate at 3 o'clock in the morning much more than not. How long does the person call? The percentage of speaking time during the conversation, the average turn length in seconds, and also then now acoustic things like the variation in energy, of zero energy, the degree of dysarthria, things like that we can analyze on the phone. We can say, okay, is the vowel space more reduced? Is it more sloppy? Is it more dysarthric? Are the typical words shorter, longer? Does it change? All this kind of stuff can be computed without invading the privacy of the person. Now, if these statistics are there, it could either mean that you don't intervene and the person goes to a regular checkup, or that the checkup is being done over the phone, or that this app that I have on my phone informs the person, informs the caregiver, informs the neurologist, he has totally changed his behavior. He has not called in the last month. Also, the GPS locator has shown that he has stayed pretty much around his apartment, and not, the circle around the apartment has shrunk. So these kind of alerts could mean that then the health caregiver is using an intervention. So it could be either a regular checkup or an on-demand checkup initiated by the changed behavior, in which situation the person who is calling does have access to communication statistics and other sensor statistics, and it could just happen that he didn't move because he was just sick and lying in bed, but it could also mean that his situation changed. So then you can perform dedicated tests or just reminder calls. Our speech analysis has shown that your medication intake you don't seem to take your medication or so. So this can be done. Now, this of course is a challenge to comparing the knowledge that we can get from the tests that we collected so far, which are very in a clinical setting, because now the patient is outside of a clinical setting. Constant testing is a burden. So, as I said, you want to test the person, you want to screen the person while he's performing his activities of daily living. So we only want to perform a dedicated test if we suspect a change. And the patient should not notice that he or she is being tested, which means that we have no control over recording condition, no control over the vocabulary they're using, and no control over the medication intake. The data that we have is we have about 500 stories of the cookie theft, and as you can see, there is for dementia, you can see there's sub-stories going on. The children are stealing cookies, the child is falling off the chair, she's doing the dishes, not watching this, water's running down, and that has to describe the image. We have the mini-mental state exam that I introduced before, state. We also have the Carolina conversation, which is 200 interviews with older persons having any of 12 chronic diseases and 400 conversational interviews with older persons having cognitive impairment. Give you an impression on a person with Alzheimer's describing this.
He must be picking up here because he's on the live air and he's got both hands open and he's ready. And the Charlotte's on. The baby's crying. That's all.
For the Parkinson, we have these typically clinical setting collections. So, for instance, 100 native Spanish speakers, gender-matched, age-matched control group, recorded in a soundproof booth. Typical task, again, as I said, vowels, words, sentences, red text, and monologues. And we have the neurological evaluation. Same thing for German. We also have that. We also have it for Czech, which this one is interesting because all the people, if you look here, all the people with Parkinson were early Parkinson, where in the German, it was up to 30 years of having Parkinson. Sorry about that. And give you some sound examples on that. No. Yeah. So you can hear it's quite dithotic speech. So it's very controlled corpora we have. We have performed experiments, and the results are pretty much, state of the art compared to the what you can see in the literature on classification of Alzheimer versus control or Parkinson versus control, and also on predicting the severity. What we did prepare for the workshop is now additional corpora to release those restrictions from the clinical. So say a little bit about, we have longitudinal, multimodal, and at-home recordings, and also a subcorpus on genetic Parkinson. So for instance, the longitudinal, we have speech of 7 Parkinson recorded in different sessions across 4 years, up to 8 recordings per patient. And the multimodal, we have speech, gait, and handwriting. So we collected not only the speech, but also handwriting and gait. This is a template that the people are supposed to draw, and the color shows the pressure with which they draw the person on the object on a tablet, with the UPDRS as a light Parkinson and a heavy severe Parkinson person. Or This is a gyroscope result from a control group, and this is of an intermediate stage Parkinson. And as I said before with the UPDRS, one of the important things in the beginning is the medication intake, because it has a very strong influence on the motor skills. So basically what we did here is we collected 7 patients, 4 identical recordings during the whole day, and the medication intake documented. In clinical collections, it's mostly you only record in on state, only right after medication intake or 1 or 2 hours afterwards. But here we just over the whole day recorded to see how this influences the articulation. Again, red text, monologue, real conversation. It's completely described, and it is also analyzed with recording not the UPDRS, but a dysarthria labeling. So all our data, all our Spanish data are now analyzed with respect to dysarthria. Questions that we will look at during the workshop is classification across different settings. That is, if we mismatch, if we go from red training data to monologues, which features are robust? Can we predict the time of the medication intake? This is a very important unanswered question so far. And it's important because then you want to call up somebody and say, after a phone call, hey, your speech is not correct. Did you take your medication? We want to look at channel compensation that is known from speaker ID approaches to see, what can we learn from data collected with a soundproof booth, and then we have real data recorded at home. Comparison of the dysarthria labeling versus the UPDRS score, which is the motor activities, complementarity of different biosignals, analysis of AD-PD subtypes, stability of features across tasks and languages, and analysis of difficult cases, which if you misclassify them constantly. So to summarize, I gave you a motivation, talked about Alzheimer and Parkinson assessment, state-of-the-art in data collection, and talked about our vision and described additional data and planned research questions. So.
I wondered if you could say a little bit more about what speech features you use, and in particular, do you have alignment between the text and the speech? Do you have alignment between the text and the speech?
Yes.
And what features do you plan to extract from it?
We have a alignment. We just use the state-of-the-art recognizer and do forced alignment. Okay. The features for the Parkinson concern acoustic features, basically in different energies in different bands. Intonation, prosody features. One of the things that we look at is if you think about Parkinson, when you see a person walk, it's kind of regular. What is difficult is the starting and the stopping. And the same goes for the vocal cords. So we not only do we use the alignment of the words, but we look at the voiced, unvoiced transition and say that's, and it turns out some of the experiments that we did before with the clinical setup, it seems to be much better than looking at a voiced part, looking at the steady state, but looking at the transition. With respect to Alzheimer, we have a lot of linguistic features that we get from part of speech tagging and standard NLP tools. And then, when you look at what we want to look at, during the workshop is if you look at how often does the person go back to a certain subsubject of the image, does that sequence tell you something?
We have a large collection of frontotemporal dementia.
Again?
It might be interesting to compare some of the techniques you're using with ones we're doing at Penn on frontotemporal degeneration.
Yeah.
With the cookie cap. We've got a
Yeah. Yeah, I also collected, I brought some data on frontotemporal description of that. Yeah, that's, to look at subtypes, definitely.
Yeah.
Change point detection. Do you want to find out when a person develops Parkinson or Alzheimer's? Observe people over time?
Ultimately, you want to do that. I don't think our data are good enough for that because, I mean, even the longitudinal, the people were already diagnosed. It's very difficult to find this change point detection. Right before the workshop, I was talking to people. There is one case where this is doable, but we don't have the data. And that is a sleep disorder. It's called REM behavior sleep disorder, where if you have that sleep disorder, your chances of developing Parkinson within the next 5 to 10 years is like 85%. And already very high within the next 2 or 3 years. That would, and certain biomarkers show, if this is the control, this is the sleep disorder people, and this is the Parkinson. So it's quite, so this is the only thing where you can really find a change point, but we don't have the data to have that. It's just that if you're diagnosed, people go there when the shaking, but when the shaking starts, then it's quite advanced already in the detection.
Another way of doing it is to monitor the genetics.
Yeah, right. We have in the collection we have genetic Parkinson, and we have people, relatives who have the same gene or who don't have the same gene, and by monitoring that's also might be interesting.
Maybe you should say a few more words because I don't think people widely know about this particular subpopulation which have this genetic condition.
Okay, Rafa is from the area of Antioquia in Medellin, from Medellin, and in this area there is a higher, there is genetic Parkinson, and there is a relatively high percentage of it, which means that you typically already develop Parkinson at age 30 or so, right?
There are different kinds of mutations. One of these is what means that you will develop Parkinson's before 30. Other kind of mutation means that you can develop Parkinson's after 50.
So these people are very cooperative, and I think you have one where 3 sisters have it, right?
Yes.
Yeah. So 3 sisters have Parkinson, and of course the family knows we're high risk, so they're very cooperative. And what Rafa did was, so we have 6 people who have Parkinson with the genetic mutation. We have 7 with the mutation but no Parkinson, and we have 6 non-Parkinson, non-mutation but relatives. And we collect the data of those, and we look at the dysarthria. They were all labeled with respect to dysarthric speech. We have there's a test, the French dysarthria test. We kind of had to modify that, and the phoniatricians they marked that. So that's one of the things. This is very recent. We really recorded all this stuff right before the workshop, to be able to go a little bit from the lab outside into the real world.
So I'm trying to understand your answer to Reinhold's question. What you're saying is if you continue monitoring this group and some of them do develop Parkinson's, then you have some data to do the onset.
Yes. Yep.
disease cases, there is absolutely no cure like cancer. If it's like diagnosed early, then there is some prevention possible. But here in Parkinson's disease, there is absolutely no prevention possible.
Well, there is, of course, exercises that can help you with the, as I said, the only thing that you can do is to try to prolong that period where people can live self-independent. But one of the things that the monitoring does make is you take up to 8 different medications. And sometimes you need readjustment. And it might be necessary to do that in between the yearly checkups. And the other thing is that there are statistics that say if you take 8 medications, the probability of you not taking it correctly is like 50%. So if we know, since we know that the medication has a strong influence on speech, if we detect something, we might just remind the person or remind the caregiver, does the person really take the medication regularly?
I think I have a related question, also on medication. Do you have information on what medications these patients might be on? Is that something that is selecting this important?
For the at-home, we did. But normally, typically, when you the old collection, typically, the Czech data the Czech data, we know they didn't have any medication. But the German data, we have 88 people with Parkinson, and we know they were recorded in on-state. That's it. We have no idea how much did they take it. Did they take it regular? We don't know. And that's very typical for this kind of data collection.